that the only band is there in the electrophoresis lane and in the lambda lane. So it's basically a lambda light chain myeloma, in which a CRP was done and it showed a value of more than 300. So reflexly we got a procalcitonin dust which was virtually undetectable. Counts were normal, blood cultures were normal. So many tests, so much money, so much time wasted just because it was showing interference with the CRP assay. Now, you must be very aware that, patients with myeloma occasionally develop hypercalcemia. So we have this criteria CRAB, that is hypercalcemia, renal insufficiency, anemia, and bony lytic lesions. So the diagnosis of myeloma is not just based on the bone marrow findings, but also on the CRAB. So this was, hypercalcemia is very common, particularly in IgA type myeloma. So there was a known, recently diagnosed IgA myeloma. My pathology colleagues had reported on the bone marrow, lytic lesions were found. We had done an electrophoresis, a big M-band for IgA, 4.8 gram per DL, and we reported the calcium as 19.3. So everything looked fine. Everything looked fine, except my physician, he said that, look, in 19.3, the patient should be really drowsy. I mean, he has myeloma, but he doesn't look that drowsy. Then it stuck to me that we are using the best possible method on arsenazole. So I consulted a friend and we did this assay on, we used these two methods. We used a dry chemistry platform for this, and we used an OCPC method, and the result was 11. So, we all know that patients with myelomas have hypercalcemia. Now, to treat or not to treat, had my physician not expressed that uncertainty that he doesn't look drowsy, what do you think? I went and saw the patient. He was eating his lunch. And really at that time it struck me that something can be wrong. A 19.3 calcium patient really looks drowsy. Now, this is a wonderful paper, it's freely available on the net. It was published by the American Journal of Clinical Pathology. You can go through this paper. It deals with the different kinds of interferences, both on the hematology front, from the microbiology front and the biochemistry front, what hematologic malignancies can do to different assays. So it's a very long list. I have only highlighted the ones which I have found, which are relatively more common. So you can have problems with sodium, calcium, even with glucose, uric acid, CRP, albumin, ASO titer, and what are the mechanisms of such spurious results, and which are the instruments by which this problem took place. This is a very good article by Dr. Dalal. He's a pathologist of Indian origin. Dr. Bokul Dalal's article in the American Journal of Clinical Pathology, 2009. Now, I've all scared you enough, so now I need to give some solutions as to what you can do. Look, for things like bilirubin, you need to see the sample once. Just have a look at the sample. Does it look like, is it icteric? Does it look like really the patient has a total bilirubin of 15? If your analyzer, very few of us use this LIH or the lipemia icterus hemolysis index, because in Western country, my visits to Europe and US has taught me that all the labs there use this index judiciously. We are bound to use it. There will be analyte specific indices which will be programmed on the analyzer, and the ISO 15189 states that any lab which is reporting results, if the integrity of the sample was compromised, but still due to medical urgency you have to report the result, we need to add a disclaimer stating that there was lipemia, there was icterus, by which the results might not be that accurate. Now, the way we do it, most of us do it in our lab, is by visual inspection. And trust me, assessing hemolysis by visual inspection is absolutely a relatively useless method. It's already fossiled in the Western world, but still, due to cost involved, a large number of analyzers have to use specifically reagents. Again, I heard 12 presentations in the last 2 days, and every presenter has actually occurred one term always, and that is cost. So lab medicine and cost is coming hand to hand. So we are not in a position to spend so much. So, it is best that we have this LIH index. If possible, we see the results. We rerun the assay. We run the assay once or twice and see that whether the variation is expected or not. The result, which was 15, might come as 14.8 because our analyzers are very precise these days. A sample of 15 should not come 10 as the second time, and monoclonal protein interferences are erratic and sporadic. Once it will come as 20, the other time it will come as 12. So the variation will be very high. You can identify by running it twice. This is the cheapest and the best method. I have picked up most such cases. Run a linearity on the sample. Make serial dilution, direct, half dilution, 1 in 4, 4x dilution, 8x dilution, as much as you can cover the measuring range. If you see that there is loss of linearity, is absolutely haywire, suspect interference. By this you can not only pick up monoclonal protein based interferences, but also interferences from drugs, interferences from the HAMA, animal antibodies, mouse antibodies. So this is the cheapest and the best available technique. And of course, this is also equally good. Measure the analyte using a different method. If you have a different method in your lab, or you can refer the sample outside which has a different method. And last but not least, the golden rule is that correlate it with clinical information always. Now, this is one technology we use in our hospital, which is relatively very insulated from it's the dry platform. Different manufacturers make it with. We use the orthoclinical platform for our dry chemistry system, and the beauty of this is that it contains a spreading and a filtering layer, which actually separates the proteins from the main sample. So these interfering proteins are removed by it, and depending on the assays, these assays are usually insulated from monoclonal protein interferences. And the principle of this assay is not the conventional Beer-Lambert's law, but a reflectance spectrophotometry. Now, what are the, we all don't have dry chemistry platforms in our hospital. So what are the other techniques that we can use? We can deproteinize samples. Now, the conventional techniques of deproteinization were salting out methods, trichloroacetic acid precipitation, ultrafiltration, and dialysis. Either these are very expensive. You can have that Amicon filters for this. This is a very corrosive acid, and I would not like to keep it in my lab. And the other one is, I have used this method very commonly, that is using a polyethylene glycol based precipitation. But, not all assays will work using these tools. Only if the test that you are doing is not hampered by the precipitation technique. I mean, it will work very well for things like aqueous soluble things like phosphate, uric acid, bilirubin. These will work very well. But if you are dealing with proteins, they will also get precipitated. So the analyte of interest will be lost. It will not work with things like CRP and HDL. But for the common ones, this will work well. So you can use any of these techniques. Now, this is a paper that we published, I and Professor Kalner from Karolinska Institute, we published this paper. We collected a couple of 13-14 cases of IgG type hyperphosphatemias. We then used a PEG-based precipitation method. We used 25% PEG, very easy to prepare, very cheap. 250 microliter of serum, 250 microliters of PEG solution. We mixed it, we centrifuged it, used the supernatant and multiplied the results by 2. And simultaneously we used the orthoclinical diagnostic Vitros platform, and there was an excellent correlation between our lab developed PEG precipitation technique versus that of the dry chemistry method. And you can keep PEG solution, it cost just 500 rupees for one bottle, and I'm sure it's going to last 5 years. So this is a very good technique by which you can correct this monoclonal protein interferences. Now, as you all know that all indirect ISC methods in patients with myeloma and very high total protein, particularly more than 12 gram per DL, all indirect ISC methods give a low value. Now, this is one more problem that monoclonal proteins cause. However, if you are using a direct ISC method in your lab, you are relatively insulated. Now, I was talking about monoclonal proteins in the analytical phase. Now, I will come to the pre-analytics aspect of monoclonal proteins. Now, this was an interesting observation that I made. We were using gel tubes, and my technologies brought me to notice that some samples were not separating. We had seen one or two cases which even on recentrifugation or collecting a second sample and centrifuging it at a higher speed did not separate. It was always that the gel was below and then the packed cells and then the serum. We could assay, we could make aliquots of the serum and then run those samples. But we discovered that most of such cases, we got 21 such cases, out of which 16 of them turned out to be monoclonal gammopathies. Now, we published this paper just highlighting this aspect that labs have a look at the sample. And this is the data of all the 16 patients. You will see that most were full-blown myelomas, and even some were MGUS, some were Waldenström's. So out of 21 cases, 16 turned out to have monoclonal gammopathies. And there are at least 4 patients in this, 2 of MGUS and 2 myelomas, where even the diagnosis was not made. We made the diagnosis by just looking at the sample and running a total protein and albumin and finding a reversal of ratio. So now coming on to the cost, the cost issues and other things. So, this was a difficult choice. I would like you to help me. I made